Hi, I'm Roderick Tung, and we are doing a retrospective case look back at last December when we did a VT mapping case with the HD grid catheter, a redo post-infarction substrate. The case history, as you probably remember, was a 60-year-old gentleman with atrial fibrillation, hypertension, but most notably an inferior myocardial infarction, had a cardiac arrest as well as a bioprosthetic mitral valve. He was upgraded to CRT, his EF declined and actually underwent an epicardial LV lead, which is important because that takes away our ability to easily get into a percutaneous epicardial access situation. The patient had 2 prior VT ablations prior to this third one and was refractory to amiodarone and mexiletine. What we did was we did a high resolution map, and here you can see structure and function. Function on the left with an isochronal late activation map, looking for areas within that low voltage, which is quite non-specific, of deceleration zones. And here you can see a white line indicates a region where there's more than 3 colors of crowding. And these are potential regions that are actually indicative of lines of block. And with biventricular pacing using a second wavefront, we were able to confirm that there was indeed a line of block, and the electrograms tell the story where you actually have split signals separated by an isoelectric segment that we arbitrarily define as greater than 20 milliseconds, telling you there's a very clear discontinuity of which is not going through that line. When we were able to pace from that line of block, we then induced ventricular tachycardia, which we often call a matched pace map induction. That tells you in a special area, and you can see the first beat matches the VT, and we were able to trigger a rapid VT that was barely hemodynamically tolerated. With strategic multi-electrode positioning with the grid catheter in that place, we can then see that we were finding diastolic representation, but there was a small activation gap in which we don't record all of diastole, which tells us there's some intramural 3-dimensionality to it. What's important about this was that we were able to get a very brief activation map, even though the maps and the systolic blood pressure were about 40 and 60 respectively. But this clearly exited the basal portion of the inferior annulus. And we will leave you with some unseen footage about 5 minutes after we cut out of a beautiful VT termination at that site, where it then breaks out the mitral annulus, and you can see our joy when it happened. So thanks for this retrospective, and enjoy.
One push or something here. On ablation here, please. 50 watts. Got it. That's it. Right at the freaking exit site. And that's what we had, right? Green coming out. If we had that live, it would have been it. That's it. But we nailed it, right? Because it's surfacing just on the other side.
Well, thanks to all of my fellow course directors for their presentations and their perspectives on the cases. It was really good to see how the patients are getting on. I'm personally very excited about Rio 2023. We haven't nailed down what our agenda is going to be next year, so do feel free to contact the Rio team and let them know what you would like to see. Obviously, our industry partners are key to this, so if they are interested in showing something or you want them to show something, please either contact us or let us know. What, do you have any feelings, Julian and Devi, what you would like to see next year? What's really interesting you at the moment?
I would, if I may start first, Devi, I would be really interested in extending and expanding the use of the toggling device RF and PFA, the lattice catheter, also maybe going beyond the PVs, going into diseased or scar tissue, and going for complex lesions, linear lesions. This I would be really interested. I would find interesting.
I think from the ablation standpoint, obviously we're still, some of this technology is still new in the US. So definitely, like you said, more on the PFA side, but also more on maybe use of AI algorithms in predicting where do we go outside of PVs. So maybe some on that. But I'm also, interested in from the non-ablation side, from the device side, probably more tools on conduction system pacing, the right tool sets. We have a lot of new tools that are coming out on that. Maybe more on the leadless devices. hoping to see dual leadless technology be out there by the time Rio 2022 is out there, 2023 is out there. So maybe a little bit more on that. I'm also passionate about appendage closure. So lots of technologies in that arena. So looking forward to seeing some new technologies, more cases, and some more active discussions and panels.
Well, you're absolutely right to remind us that innovation is not slowing down in heart rhythm management, and there's so many really interesting, exciting things I'm looking forward to seeing next year. And I hope you don't miss your chance to be part of Rhythm Interventions Online 2023, where innovation, collaboration, and inspiration converge. Register now to secure your place and join us for 3 days of discovery and innovation on the 29th of November to the 1st of December, and we all look forward to seeing you there.